Good morning, everyone. My name's Adam Saltman, and I'm the Chief Medical Officer for ECHO. I'll be your moderator today. I want to say good morning, good afternoon, and good evening, because I know everyone is coming from all over the world, so wherever you are. I know how excited our panelists are to be here today discussing today's topic and answering your questions. I'd like to say that we've had over 1,000 registrations, which is quite amazing, and we're very flattered and honored to have you all here today. I've seen from our list that you come from all walks of life, which is really impressive. And of course, it's not a surprise that most of you are clinicians and healthcare administrators, but we've also noted that there are a number of CEOs, COOs, CTOs, and even a boss man on the list of job descriptions. So whatever your title is today, I hope you all find this webinar informative, thought-provoking, and useful. Before we get started, I'd like to cover a few housekeeping items. First, we at ECHO provide healthcare professionals with digital tools to hear and understand their patients' hearts and lungs, helping patients detect and diagnose disease, manage treatment, and ultimately give their patients the best care possible. In our conversation today, you might hear us talk about our digital stethoscopes and their ability to live stream sounds or record them during a physical exam. And although it's not the focus of today's discussion, we'll also touch on some of our disease detection algorithms that help clinicians detect heart murmurs and atrial fibrillation. Second, I'd like to alert the audience that we will be playing recorded heart sounds at certain times during the webinar, which I'm proud to say I think were recorded using ECHO devices. But in order to best enjoy the experience, please wear headphones or earbuds, not using your laptop speaker or other speakers. Third, there will be time at the end of the webinar for audience questions. Please enter them into the Zoom Q&A box that you can access by clicking the Q&A icon at the bottom right of your screen. Note that the chat box will be disabled for the duration of the webinar. Fourth, any opinions, professional practice examples, or workflow examples discussed during the webinar are the opinions solely of the speaker and are not the position or opinion of ECHO. And fifth, and most important, I would like to express many thanks to our partners at HRS for co-hosting this webinar with us. And now I'm pleased to introduce our panel of experts. Going in clockwise order around the slide, starting with Florence Kariuki, I'd like to have our panelists tell us a bit about themselves before we start our discussion. Florence?
Thank you so much, Adam, and good morning, good afternoon, good evening, everyone. To Adam's point, I am Florence Kariuki. I'm Chief Clinical Officer at Health Recovery Solutions. I've been with Health Recovery Solutions for the last 3 months. Prior to that, I was with a health plan, Horizon Blue Cross Blue Shield of New Jersey. And at HRS, basically what we're doing is enabling our clients with providing remote patient monitoring and virtual care solutions. And we're really excited to be part of this panel today. And also I'd look to share my experience from health plan standpoint, working to develop value-based programs, as well as population health initiatives, which I know many of you are focused on. Adam, thank you so much for having me on today.
Great, thanks, Florence. Peter?
I'm Peter Sullivan. I'm a professor of medicine at Oregon Health Sciences University, and I've been teaching the physical exam for the past 23 years here, both as an advanced course where I first met Andre as a third-year medical student and as a required course for the first and second-year students.
Thanks, Peter. Mary?
Hi, I'm Mary Ross. I'm Chief Clinical Officer for a visiting nurse company, Visiting Nurse and Hospice here in Fairfield County, Connecticut. And I've been working with telehealth since 2003 and happy to have HRS as a partner and that they've added echo stethoscopes to practice, and we are using them on a regular basis.
Great, thanks, Mary. And Andre?
Hello, I'm Andre Mansour. I'm an internal medicine clinician here in Portland. And I work with Pete. Both he and I are hospitalists at Oregon Health and Science University. And together, we actually, in addition to teaching that exam course that Pete had mentioned, we also run a website that's entirely free and educational, physicaldiagnosis.pdx.com. And many of the sounds that can be heard on that site were recorded with echo stethoscopes. And so we're very grateful for that. And we're very happy to be here today. So thank you for having us.
Terrific. Thank you, Andre. Here we're acknowledging our participating organizations, which you heard all of the panelists coming from. So now let's start our discussion. Our topic today is revitalizing the physical exam for the future of healthcare. And so our first question really has to be, what is happening to the physical exam? And Pete, I'm going to start with you. I've personally observed during my career a concerning decline in the practice and utilization of the physical exam. In fact, when I was in practice, my residents used to ridicule me for taking the time to perform an exam and demonstrate physical findings to them. So I'm curious, are you seeing the same phenomenon? And if so, what do you think is contributing to that trend?
I've been seeing the same phenomenon for my entire career. I got my MD back in '94, actually reading older literature on it. I think people have been bemoaning the demise of the physical exam for the past 50 years or so. So I don't think it's really changed. I think there's a number of reasons. One is that people oftentimes aren't seeing the effectiveness of the physical exam. They're not seeing people who are actually good at the physical exam and see how it's beneficial to them or beneficial to their patients. So I think it's probably this lack of modeling and mentorship that's really lacking.
Oh, and by the way, if others have opinions, please feel to throw in. I wanted to ask Florence or Mary, because you have contact with a technology solution. What's the point of view from your perspective?
Yeah, no, Adam, thank you so much. And I couldn't agree more with Peter. And we're working with multiple clients and seeing, growing use cases for virtual care. I think from where I stand, I think some of the challenges or limitations to physical exams continuing to be part of the care is even just in the limited access to the resources that enable that to be done effectively. For most clients who are providing virtual care, generally it's the common, blood pressure monitor and weight scale, and so if for that virtual care there isn't something that enables a full end-to-end, head-to-toe assessment, they only use what they have available. And so some of it is really just truly resource limitations, and which excites me, the fact that, HRS, we've embraced EquiDuo as part of those peripherals that we offer our clients, to help really optimize the capability of providing an effective head-to-toe physical exam. I know, Mary, you were going to say something, so I'll tap it over to you.
Well, just to tag on to what you said, Florence, when looking for a vendor for telehealth, I went looking for one that had a stethoscope, because in reality, you want to, as much as possible, replace the on-site visit with the telehealth visit. And you can only get so far with a heart failure or COPD patient and even others. When you get to a point with the vital signs, you realize the pulse ox is low, the patient's having dyspnea, you've got to send out a nurse. And really, we need a system, which we have now, where we can do that exam as much as possible virtually.
Yeah, I think that's a great point. And, there's kind of a split forming now, because as telehealth becomes more of a part of our regular practice in some way or other, how do we continue to perform exams? And so, Andre, I wanted to ask you a question. I mean, despite the advances in diagnostic technology, why is it still important in your mind that we continue to perform, excellent physical exams?
Well, yeah, Adam, and just to answer the question that's on the screen, the way I would answer this, I would say that nothing has happened to the physical exam. It's just as powerful today as it was 100 years ago. And it really is the clinician that has changed, and not for the better. I think there's been this over-reliance on technology, this movement towards over-reliance on technology and under-reliance on the fundamentals of medicine, including the history and the exam. And that comes at a great cost to patients, both literally because testing, over-testing, and unnecessary testing costs money, but also figuratively because unnecessary testing tends to beget more unnecessary testing and eventually an invasive procedure. You can imagine a patient who, let's say I order a CT scan on unnecessarily and it shows a lesion in the liver, that it may be benign and doing no harm to the patient. All of a sudden now we're obligated to biopsy it. And now, that a bleeding event happens during the biopsy. Now they're fighting for their life in the ICU. So, there's really, it comes at a great cost to patients when we over rely on, MRIs and CTs and testing of that nature, and under rely on the history and the exam. And also, underutilization of the physical exam leads to delays in diagnoses. And, both Pete and I over the years have seen many cases of patients, whose diagnosis was delayed by, weeks, and in some cases months, many months, because a physical finding, which was there to be seen or heard, was completely missed. And, that identification of that finding would have made the diagnosis sooner. So patients are suffering as a result of this. And, in some cases, the exam can provide clues that the technology I alluded to will miss. And there's actually a case that I'd like to share with you all that I think is a good example of that. If we could advance the slide. So this is a young man who comes into the hospital with fever and chills, and there are a few skin findings here to be seen. And hopefully some of you out in the audience can recognize these findings. The findings on his hands were tender nodules distributed over the thenar, hypothenar areas and pads of the finger. Classic distribution for what's known as Osler nodes. And then on the sole of his feet, we can see these macular lesions that are non-tender, and these are known as Janeway lesions. And clinicians in the audience might sort of think, well, could this patient have infective endocarditis that these findings are characteristic of? And so with that sort of hypothesis in mind, we would go to listen to the patient's heart. And anytime, and I learned, this is something I learned from Pete, which has served me really well in my career, is anytime, you go to examine a patient, you should anticipate what you might see, hear, feel. Otherwise, you're liable to miss it. And so when we go to sculpt the heart in this case, we're specifically listening for finding that might be consistent with infective endocarditis. And let's take a listen over the apex of the patient's chest here. And so take a moment and just try to digest what you just heard. I'll describe what I am hearing. What I'm hearing is a holosystolic murmur, and it's meaning it's panning across the entirety of systole, and it's flat and plateau in shape. And so we have a gentleman here with Osler nodes, Janeway lesions, and a systolic heart murmur that's consistent with mitral regurgitation. And the diagnosis here is infective endocarditis. But the story didn't end here. A few days into his hospitalization, after we had diagnosed him with mitral valve endocarditis, he developed, his heart sounds changed from what we had just heard into this. And I think this one might be worth playing one more time, but let me describe what I hear, and that way the audience can try to listen for it. And maybe you already picked up on it, but the heart sounds have clearly changed in some way. We no longer hear this murmur. What we hear these scratchy sounds, and there are 3 of them, kind of like creaking leather. This is a pericardial friction rub, and we should play it one more time. So now we know that this patient's endocarditis has now evolved to affect his pericardium, which is an important thing to know. And by the way, acute pericarditis is not always associated with a pericardial effusion. And so if we were just relying on echocardiograms, for example, this is something that would have been entirely missed. Only the stethoscope can appreciate this sound and could have made this diagnosis at that moment in time. So now we know that his pericardium is involved. A few days later, the situation changes even more. So the patient becomes hypotensive. He's feeling like he wants to pass out. His pericardial friction rub has completely gone away. And in fact, all of his heart sounds were a bit more distant. And this is what his neck veins look like. So you can clearly see distension of the external jugular veins. He's in the upright position, by the way. So this is frankly abnormal. This is known as jugular venous distension. You can also see the IJ hiding back there. So the central venous pressure is quite elevated. And how can we put all of these things together to come to a diagnosis? So his heart sounds are more distant. He's developed hypotension and elevated jugular venous pressure, while the astute clinician, knowing that his pericardium was involved days before, would be able to predict and make the diagnosis right there at the bedside of cardiac tamponade, which is a life-threatening condition that requires, immediate diagnosis in order to provide the best care and the best chance for the patient to survive this. And I think this is a nice example of, how the exam can evolve on a day-to-day basis, sometimes an hour-to-hour, even a moment-to-moment basis. And that's why this is just one example of why physical exam is so critical. First, because the echocardiogram would not have picked up the pericardial involvement. And two, because it allowed us to observe and identify and recognize evolution on a moment-to-moment basis in this case and make a diagnosis right away.
I think that's an amazing example. And when I was in practice in cardiac surgery, that was usually the Friday night when I would get the phone call to go relieve the tamponade. And I would go up to find the patient, and guess what? They were sent for an echocardiogram. And I'm like, what are you doing? We need to go right now. So yes, exactly. Tremendous example. I know, Pete, did you have an example that you wanted to show us?
Yeah, I've got a case. Andre and I took care of this patient. So this is a 26-year-old woman whose only past medical history was palpitations that had been diagnosed a few years before. So she woke up one morning with right arm numbness, a pressure feeling, and weakness, and felt as though her tongue and her face were numb. So the numbness lasted for about 5 minutes, but she still had this sort of feeling of heaviness that persisted. So she went to her local emergency room. There they documented a completely normal examination, except what they said was 4 out of 5 right upper extremity strength that they thought was limited by shoulder pain. They called the neurologist. They had a CT of the head and the neck that were normal, and they discharged her home without a diagnosis. So the following day, she comes back in. She woke up with severe right lower quadrant pain. Her exam, again, was documented as completely normal except for mild to moderate right lower quadrant pain. They got out their POCUS and they found that she had some mild hydronephrosis. Her gallbladder wasn't visualized. Her aorta looked normal. They were concerned about appendicitis, so got a CT scan. And what the CT scan showed, you can see here, her right kidney looks really abnormal. So she's got a right renal artery infarct with complete occlusion of her right renal artery. So they called the interventional radiologists and extracted the clot and put her on heparin. And shortly thereafter, she developed hemoptysis. They got a chest x-ray that showed some patchy alveolar edema or hemorrhage. They were concerned that maybe she had a pulmonary embolism, which because she had this arterial embolism, and I'm not sure why they thought that, but they got a CT. It didn't show any PE, but showed diffuse alveolar hemorrhage. And you can see that here on the CT scan. Being a young woman, they started thinking about autoimmune illnesses. They ordered ANCAs, anti-GBM, SED rates, ANAs, ENAs, all this sort of stuff. Her hemoptysis became worse. They took her to the MICU, did a bronchoscopy and a BAL, which basically just showed evidence of bronchitis. So there she was in the ICU, intubated after her bronch. And let's go back and see what they actually could have picked up on examination, I think on the next slide here. So take a listen to this. This is one where I think you really do need headphones because some of the sounds are a little bit on the lower pitch side. So take a listen, see what you think. So I think that one of the main failures here was that none of the clinicians could appreciate that this heart sound was abnormal. And I think we don't have to all be trained to be able to diagnose every different iteration of every unusual heart murmur. But I think this is one where you could say, is the heart normal or not normal? And if it's not normal, maybe that is the clue to the diagnosis. So I actually brought this heart sound recording home to my 16-year-old daughter, who's got very little in the way of auscultation experience. And I asked her to listen to this, and she listened to it, and she started humming, "Weem away, a weem away, a weem away." And I think if you listen to the murmur again, I think you'll appreciate that that's exactly what it sounds like. So you can see on the annotations here, there's a loud S1 followed by an S2 with a little bit of a pause. There's an extra sound, and then there's a murmur. And I think if you listen, I think you can appreciate that this is a long murmur. It's not a short murmur. Long murmurs mean diastole. This is a diastolic murmur in a young woman who's got unexplained embolic events. So let's go to the next slide and see what we think could be going on here. So what would tie this together? Give me a minute to think about it. Well, what she ended up having was mitral stenosis. And the diagnosis was delayed. It had actually been delayed for several years because she had seen multiple providers for shortness of breath, sudden onset shortness of breath, palpitations. This was from her intermittent atrial fibrillation that was going on because of her mitral stenosis. And this was something that was so easy to hear. And I think a couple of reasons why it wasn't appreciated. And I'll share that with you. When I brought other learners by to listen to her, they would listen at the aortic spot. They would listen at the pulmonic spot. They might go down to the tricuspid spot, but she's a 26-year-old woman. They don't want to inconvenience her to have her lift her breast to listen to her mitral area. And if you didn't listen to the mitral area, you wouldn't hear this murmur. So I think in thinking that we're inconveniencing the patient, we're actually putting them at grave harm by not doing a thorough examination. And she could have avoided having a stroke. She actually had some permanent deficits from the stroke, ended up having her valve replaced. And I think if this was found earlier on, all of this could have been avoided. All these tests that she had done that were completely unnecessary would have been avoided.
Yeah, and even those complications of pulmonary hemorrhage and embolic infarct of her kidney. So yeah, terrific points. I mean, those are very impressive examples. One of the things that I realized as you were going through the examples, and we talk about this inside echo a lot, is the utility of the phonocardiogram, because both of you really went through the phonocardiogram there. And I'm wondering, especially as we are leveraging technology and recording these sounds and displaying them, not just listening to them, but also displaying them, do you see added value in the phonocardiogram itself and having people see it, read it, interpret it, things like that?
Absolutely. So Andre and I will oftentimes try to work with learners on heart sounds. And oftentimes they're confused about what part of the cardiac cycle they're in until they can actually see it displayed as they're listening to it. And then it really becomes much more clear. Whether you're talking about a third heart sound, a fourth heart sound, a murmur that's systolic or diastolic, I think it's a really useful tool in helping teach murmurs and interpret murmurs.
I couldn't agree more with that. In fact, the first time I ever heard the term phonocardiogram was from Pete a long time ago, and when I was a student, and we'd always talked about how that was the technology of the day, you know, before echo and things came out, and so we had always tried to find one, you know, an antique phonocardiograph machine, and we'd always talk about it. We couldn't find it, so for years and years we looked and looked, and finally one popped up for sale on a website, and so we went ahead and ordered it, and it came in, and it was 1958 was the year this machine was made, and so we, after some additional work, we finally got it to all work out, and so we have this 1958 phonocardiograph machine, and it still works really, really well. And as Pete mentioned, it's great for teaching purposes, and that's the reason why we were so interested in it to begin with, is because if you can provide students and learners with two modalities, two sensory modalities, not only auscultation but also the visual aspect to it, it's so much easier to understand, as Pete mentioned, where you are in the cardiac cycle. Where is it? What is this extra sound I'm hearing? Is that next to S1 or is it next to S2? Is it in systole or is it in diastole? And so having both kind of auditory and visual modalities simultaneously is really critical for mastering, these sounds, heart sounds, lung sounds, etc.
Yeah, and I just want to chime in to say, this takes me back to, I spent, while going to graduate school, I spent some time teaching nursing students how to do effective head-to-toe assessments. And I feel like this is such a great opportunity for us as we continue to see more nurses moving out of the bedside and going into virtual care positions. Many times nurses serve as that sort of first filter. They're touching patients, they're listening to lung sounds, they're identifying opportunities to call in, cardiology for additional follow-up. I think there's just so much opportunity for us to, enhance the training and really leverage all of these kinds of phonocardiogram with, type visuals and sounds that go with it to enable just a really effective skill capacity. And I mean, I'm thinking, I think, and Mary, I don't know if you had this, but I think back and I don't recall having this as part of my training, but I just see that there's so much opportunity as we move forward with more and more nurses conducting assessments virtually. And, and I also served as a telemetry nurse in my previous life. And so listening to lung sounds was part of my life, and, being able to read EKG strips effectively. Again, just so much opportunity for us to leverage this as we move forward in a really technologically driven healthcare industry.
Yeah, I agree with you, Florence. And I think that what I try to encourage nurses with the technology, because some are really reticent to use it, is to say it's just a tool to help you be a better practitioner. Mm-hmm. And there are so many things that you can use it for where you start to really learn more about your patient and see patterns. And especially if you have the opportunity, as we do with HRS and Echo, to see the patient every day of the week. And then we can also send these reports directly to the doctors, and we can collaborate and we can learn as they diagnose. So it's very, very cool.
Yeah.
You brought up a really interesting point, Mary, which is that, the phonocardiogram is something objective. Listening to the sound has some subjectivity to it, right? And so to the extent that you could document something objective, it's something that you can then follow as the patient progresses. So we know aortic stenosis murmurs change as the disease gets worse. If you can compare phonocardiograms over time, maybe it's a way to follow patients objectively, particularly as the patient's physician may change over time or something like that. So anyway, just an idea that popped into my head there.
Very cool.
Well, I'd like to change gears a little bit. We're going to do a live poll now of the participants. And while that's being set up, I'd like to say that a few days ago, you probably saw a LinkedIn survey where we polled people asking them if the physical exam is indeed losing its importance. And the response, much to my happy relief, was that 86% of respondents said that the exam is either still important or it's losing its importance but must be revived. So I think that most people still do believe in the physical exam and its value. And so that's great. And we'll continue pressing ahead in our webinar today to delve into that. So while it says I can't vote. All right, so I'm not allowed to vote. But while the results are coming in, I'd like to say that there are definitely, questions here, like what are the obstacles? What is preventing people? You've seen the value of the physical exam, but what is preventing people from doing the exam? Is it lack of time, lack of reliable tools, inadequate staffing resources, lack of training, lack of confidence in the information that they're gathering or hearing, or an over-reliance on diagnostic tests? So what I'm wondering, and what I want people to start thinking about on the panel here while we're waiting for the results to come in, is kind of entering the future. And that's the second part of our mission statement here, right? Today is the physical exam into the future of health technology, healthcare. And so I mentioned earlier telemedicine, and we know it's here to stay. It's not going away. It's going to be a part of our care. Certainly not 100%, but it'll be some part of our care. And we also know, and there's actually just a paper published recently on a survey of physicians taking care of veterans, that video encounters, video only is not sufficient. Patients don't feel comfortable with that. Physicians don't feel comfortable with that. And so we need to focus our discussion, I think, on the challenges we need to overcome in this brave new world of physician-patient encounters. And what are we going to do to keep the value of the physical exam? So, the results are just in. So let's see. The number one choice for preventive, for something that is preventing a physical exam is lack of time. 56% of people said lack of time. That was actually followed very closely by over-reliance on diagnostic testing. And the rest of them kind of fell much further behind. Lack of training was around 40%, but the two big ones were lack of time and over-reliance on diagnostic testing. I think that's very insightful. So actually, let me turn to Florence here and say, what's your take on that? I mean, in terms of people saying lack of time, but very closely, diagnostic testing. I mean, how do we overcome those challenges?
These are great. This is such great feedback to see what people's responses, Adam, to your point. And I think it's the question, we're sort of in this pivotal moment now where we have to rethink how we've delivered care. We've had primarily care given in person, and the ability to do that head-to-toe assessment and auscultate and all of those important touch points. And now as care moves further and further away, and we're forced to leverage telemedicine, to your point, Adam, I think we have to begin thinking about, and I think it was Pete that said this, or Andre, technology is not the way that, we're going to do the care. It's what's going to enable us to do the care. And so part of what we've been doing at HRS is helping our clients think about how to make an effective virtual care visit and really optimize it from beyond just a video visit. How do you leverage all of these different devices that continue to grow to truly assess and touch that patient, and how do you break out your time so that you're doing all of those things and documenting? I think part of the benefit is when you're doing it virtually and you don't have to drive back and forth, or if the patient is not driving back and forth, there is an increased capacity to either take on more patients or spend a little bit more time with the patient who's well trained to use those devices. But certainly limited time, I think, is one that using virtual care effectively, using the devices that can be able to support those important assessments, using all of those to enable that effective assessment. I think that's one way to address that. And when you talk about excessive reliance on diagnostic testing, I know I put back my hat. Like I said, I was previously with a health plan, so many times I was digging through claims data to understand, what's happening to the patient. That is truly one of those, high cost drivers that exist in the industry today. And I feel like we're at such a risky point now. I will say for myself, I am a touch-feel nurse. I wanted to touch my patient and feel and press that edema and know how deep it goes, and sort of not being able to do that. It's very easy for us clinicians to want to rely on whatever else can help us feel comfortable. But again, I feel like we're in that pivotal moment where we are going to have to learn how to leverage what exists today that can help us get that level of comfort, again, without over-reliance on diagnostic testing. But I think it's going to be a very interesting future for us as we evolve. And, and part of it is also just having equipment that is reliable, that we can trust, and many factors, influence that. Sometimes it's things just as simple as Bluetooth connectivity. Can I trust that the reading that came through is correct, is accurate? So I think having that trust in what we're using, and then being very comfortable that the patient knows what they're doing, if they're doing it themselves or the virtual person that's conducting it remotely is doing it effectively. I think all of those pieces will come together to enable an ongoing future of a physical exam being conducted.
Terrific. One of the things that I'm wondering about it as you went over that is sort of the interplay of time, diagnostic testing, and cost. And I wonder, do other panelists perceive that it may be the lack of time that's driving the excessive testing or the unbelievable high reliance on diagnostic testing? I don't have time to spend with the patient. I can't do the exam I want to do, so I'm just going to send them for a test. Or is that not the only reason? Are there other reasons?
Well, speaking from the visiting nurse standpoint, I think that we'd be more inclined to send the patient off to the hospital and incur those costs if we did not have the adequate tools to assess the patient. And yet, and every time we prevent a hospitalization, for example, for heart failure, I think the average cost in the country is around $16,000. So we're saving a lot of money for the system, but we're also able to give the patient the care at home without creating a lot of disruption in their lives. And God only knows what tests will be ordered once they get to the hospital.
Can I say a few words, Adam?
Please.
So I don't want to discount the lack of time, but there are also some diagnoses that are known as Augenblick diagnoses, so in the blink of the eye. And Andre and I have frequently seen patients like this, where you walk in the room and you see the neck veins all the way up to the earlobe. You see dilated veins on the top of the patient's head. You see the moon phases of Cushing's. We actually had a medical student who just emailed me about an encounter that he had, where he saw a woman in clinic a couple of months ago who was losing weight and was weak, and he noticed that she had fasciculations, and he brought up a diagnosis in clinic that wasn't really recognized, I think, by his preceptor. The patient ended up spending 2 months in the hospital, seen by multiple providers, neurologists, critical care physicians, and eventually they came up with the diagnosis that he made in seconds just by looking at the fasciculation. She had ALS.
Wow. Yep.
And I'll chime in as well if there's time. I would say in my experience that there are three main reasons why I think the physical exam isn't done or isn't done properly. I think time is one of them. I think that there are individuals who value the exam and they have the skills to do it. There's a lack of time, and I think that there's just this push to see more and more patients. I found myself in a situation, a couple of years ago where our census was very high, and I had to just run around, and I couldn't spend any time with patients, and I was just trying to balance a ton of patients on my census, and I ended up missing a diagnosis of endocarditis, and that really hit hard because I found myself in a situation where these external factors were essentially not allowing me to practice a good quality of medicine, and so time is, I think, a factor. And that's a sad reason why the physical exam is not done. And oftentimes it's not the fault of the clinician. The second reason, is that there is time to perform an exam, but the clinician might lack the skill or the competence, and that's a sad reason also, but it's forgivable because this is something that can be learned. And Pete and I are still learning every day. We're in the hospital, we're learning new exam tricks and seeing things for the first time. And so it's kind of a lifelong or career-long thing. So, but that can be remedied. But the third reason, perhaps the most unforgivable reason, is they have the time, and maybe they have the skill, but they don't believe in the utility of the exam, and that's, I think, a real problem. It really starts with understanding that the exam is incredibly powerful. And that's why Pete and I have, spent so long trying to build this website to show, example after example of where the physical exam was critical in making a diagnosis and ultimately helping patients. So I think that's where it starts, is a belief in the utility of the exam. And some people don't have that, unfortunately. But it starts there. And once they have that, then it's a matter of just building the skill over time.
Yeah, you've actually tied together a couple of interesting ideas there. And so by lacking skill and saying that it's something that's teachable, it kind of touches on the topic of education. And so I'm interested in hearing the panelists' thoughts about using technology to help with education. How can we do that? Where should we do that? How do you see it being used and helping to keep people's exam skills up so they do have confidence? So I'd love to hear, your thoughts on that.
Well, in home care, we're using it for wound care rounds so that we have the nurse, the wound care nurse, certified wound care nurse, examining all the wounds. And through both our EM and our telehealth programs. And then this saves a lot of time because we only have 2 wound care nurses and they can see 100% of the wounds and the progress being made as well.
Yeah, I mean, I think it's a little scary to me to even imagine that a clinician would feel comfortable saying that a physical exam is not necessary. I mean, to me, it's mind-boggling. How do you truly feel comfortable with your decision or assessment of a patient if you haven't conducted a physical exam? And maybe it's my training, but I struggle even embracing that. And to your question, Adam, I think there's just so much opportunity for us, like I mentioned before. I think about, and again, speaking from a nursing standpoint, I've gone through, nursing education. And as nurses continue to go into roles that require them to be comfortable with providing care virtually, and so being able to assess patients and be able to communicate that information with physicians for follow-up and to make referrals, I think there's such opportunity to look at the curriculums and look at the the clinicals, and parts of those are done in a inpatient setting where they're touching the patient, but some of those need to be turned into remote clinical training sessions so that they're leveraging phonocardiograms and remotely received biometrics and things of that nature to test themselves with how well they can effectively assess that patient or manage that patient, and then maybe compare that with an in-person visit with the same patient to see, did they miss, did they catch everything they were supposed to? And many organizations are currently thinking about different ways to develop telehealth savvy students. And certainly for us from an HRS standpoint, we've developed learning credits and what do I call, certifications that are available, and we are happy to partner with universities and anybody else, just to think about leveraging the opportunity to use technology to enable effective virtual care delivery, because truly this is the way of the future, and we have to be comfortable that our nurses and our physicians, respiratory therapists, and again, I bring in even other ancillary services because I think CMS just recently released some codes under what they're calling the remote therapeutic monitoring that will cover for musculoskeletal status and respiratory status monitoring. And so that's going to enable physical therapists, respiratory therapists, speech language pathologists, and including nurses to bill for remotely provided care. And so for me, I think there's just such an opportunity for us to ensure that education for all of these clinicians that are touching patients ensures that they're very comfortable leveraging technology, but not using that as sort of the only way, but being comfortable to continue providing the care that they've been trained to do with technology as a support system.
And I would add that there's an opportunity for peer evaluation that didn't exist before, because as your encounters can be recorded, and then you can get feedback from your peers on how you might do things better, or they might learn from your methodology.
Oh, that's a great point. I hadn't thought of that, but that's a fantastic use of that. One of the things that Pete and Andre were talking about earlier, I think, Andre, you mentioned really that this is a lifelong learning process and you're constantly learning new things. And Pete, you said that not everybody has to be an expert at hearing everything, but at least, hey, there's something wrong here. And so we've talked fairly extensively now about sort of the at-home type of telemedicine and doing, education and using technology. But what do you think about the opportunity of kind of the immediate expert on the spot kind of telemedicine, where a primary care physician, for example, could pick up something? They might not be an expert in auscultation. It could be confusing. They don't know exactly what it is. Leverage that type of technology to get a cardiologist on the line and, hey, can you listen to this? And everybody learns, a diagnosis gets made. I mean, is that a possibility?
Absolutely. I think that with the example that both Andre and I gave, the heart sounds were so clearly abnormal. And again, you don't have to be an auscultation expert to know what it is, but just know that it's really abnormal, and it's something that then needs to be followed up either by having somebody who is an expert listening to the sounds to help it out, or going ahead and then ordering a formal echocardiogram to see what's there. And this is one where, again, to all the nurses out there, if you're taking care of one of these patients and you listen with your stethoscope and you hear this, you can then alert the clinician who maybe didn't listen as astutely as you did, since they're not spending as much time at the bedside as the nurses are, and say, hey, doctor, I'm hearing something abnormal here. Can you take a listen and tell me what you think it is?
Yeah, well, I mean, you guys know from having used our products, they record the sounds and stuff. So they are connected by Bluetooth to the phone, and from the phone, you can store them, share them, et cetera. So the whole idea of making it a connected environment is there. The underpinnings are there, ready to be used. So yeah, that's pretty cool.
Pete and I use that all the time. In fact, Adam, we both have accounts obviously with Echo, and it's so easy to record, using Bluetooth. It's just, there's no wires or anything. It's literally just your recording device, and you just listen and it records automatically, and then it sends it to the site. And if you're, if you have an account, you can log in. So Pete and I will share sounds with each other all the time, and we'll blind each other to it. So we won't say, what it is that we're hearing. And we'll say, hey, take a listen to this and tell me what you think. And that we sort of keep each other honest that way, and we learn from one another that way. So yeah, it definitely is doable. And this happens. I mean, people send me neck veins on Twitter, from time to time, and say, hey, I saw this in a patient. What are you seeing? And I've been able to I think help in a few cases. And so I think it is definitely doable, and it's happening. But yeah, I think it's a reasonable thing to consider, using the recordings from the Echo devices to share it with others who might be able to recognize what sound is there.
And just a wild guess, that's how you got the sounds onto your website. Also the same way, right? So
yeah, exactly. Yeah, we've used the Echo scope for most recordings. And again, speaking to that original question about how can we leverage technology, and this is a way. I mean, with textbooks, they would draw out the phonocardiogram, on the page, and you would see it. Okay, this is what aortic stenosis looks like, should sound like, but you can't hear it. Obviously, this is what mitral regurg should look like or sound like, and you're left with just dynamic or just static images in a textbook. But what the website allows is for dynamic media, like audio files, where it's paired up with the phonocardiogram, or videos of the neck veins that you appreciate in a textbook. So it really helps learners, transition from the textbook to the bedside. It's that bridge between the two, using audio and video to kind of help transition.
great.
Back when Andre was my student,
Oh, I'm sorry. Go ahead.
I was going to say, back when Andre was my student a few years back, then he took a 2-week elective with me on advanced physical exam. And back then I had to wait for a patient with an unusual heart sound to come into the hospital to bring Andre to the bedside. Now we have this library of hundreds of recordings of virtually any heart sound abnormality that he and anyone in the world could listen to for free and work on their skills that way. We have quizzes on it, and this is all made possible by the technology of these electronic recording scopes.
That's great. That's terrific.
As well as our fabulous colleagues, Joe Nugent and Ishita Sharma, who do an absolutely astounding job curating this material and putting it on the website for everybody. So shout out to them.
Well, that's terrific. We only have about 8 or 9 minutes left, so I wanted to basically ask Mary, as we said, you know, nobody really knows where telehealth is going to go. Nobody really knows who really should even be encountered by telehealth. I know it's not going to be appropriate for every patient every time. There's going to be some kind of decision making at some point. But I do believe you put together a couple of examples for us showing the utility and the benefit. So please.
I'd love to talk about it because these were great examples. And one of the great things that happens in home care with telehealth is that you get the patient and family involved in the exam. And while that may seem intimidating at first, they really get into it. So we do collaborate with the on-site nurse. Every patient has an on-site nurse. And then the telehealth nurse will go out and educate on the equipment. And here is an example of the diagram that we give. And I've even known patients and families to put little dots on their family members on the back so that everybody is measuring at the consistent point. And back at the office, then we will do a test. And we have somebody at the patient bedside, somebody at the office, and we're having them move through the various points of the lung sounds. And we get a teach back from the caregiver on the visit. They can record. We have them take several deep breaths and record the sounds. I prefer real time, but we can do either one and listen to the recording later. And then we have this woman on service, and her nurse was very attached to her. She was 88 years old, and I convinced her to let me put telehealth in there. And we had, she was end-stage COPD. She'd been in the hospital every month for at least 3 months in a row, if I remember correctly. And so we put in the telehealth, and every month at the beginning of the month, she'd say to me, you know what this is? And for the last 7 months of her life, we were able to attain her goal of keeping her at home until she died and no hospitalization. So we used the zone tools to teach her. We told her when she gets into the yellow zone and God forbid the red zone to call. And with that, I was able to see her within a number of minutes. Whereas right now, and particularly with the nursing shortage, it could take hours to get somebody to see a patient. And that's where we end up having to call 911 if they're short of breath. So 15 minutes is generous. Usually it can be within 5 minutes. And then we can get the physician right on the phone, report the findings, the wheezes, diminished lung sounds, low pulse oximeter, higher respiratory rate, and so forth. And within 30 minutes, I remember one event where she was in a lot of distress, and just by being able to respond to her so quickly, we immediately decreased her anxiety, which contributes to the whole cycle. And we were able to keep her home, and she was very comfortable within hours. So in another case that was profound, this man had so many comorbidities, 86 years old, a veteran, heart failure, COPD, depression, anxiety, diabetes, benign prostatic hypertrophy. And he'd had 4 hospitalizations. He was getting toward the end of life as well. And he was fighting to stay alive for a very important reunion to him. He'd had heart failure exacerbations, pneumonia. He had an implanted defibrillator, UTIs, the whole bit. And with telehealth, we had daily monitoring. And this was a gentleman, just so you know, I'm speaking to Florence's point about hands-on nursing, which we all love so much. He had to come to the office at one point to meet me in person, but we had developed a really strong relationship through the telehealth. And listening with the stethoscope, we were able to really lives many times so that we didn't have to send him to the hospital. So he had no hospitalizations in that last precious year of life. And why do we need this? And why do we need a complete virtual visit? So by 2030, I think we're going to be short 1.3 million nurses in this country. And they talk about on the American Nurses Association webpage about losing the expertise of people who are hitting their 60s and getting ready to retire. Well, I would argue with telehealth, they wouldn't have to retire. And also where we are, we're in a very congested area in Fairfield County, and getting from home to home is ridiculously hard. We have 6 patients that a nurse can see in a day if she's in her car, and easily 10 that she can do on telehealth and do quite a thorough job. Involving the patient and family as well, we can get a lot of the visit done, even photographs of wounds and edema that they can ship up to us before we actually have the one-on-one exam. When they're doing their own vital signs too, I find that they ask you more questions about what does 140/90 mean? What does that heart rate mean? Is it normal? Is the blood sugar normal? And so it opens up a whole different kind of patient interaction. And I feel that they are more engaged in their care, and it proves patient satisfaction because of the responsiveness, but also because of the engagement. And I just absolutely love it and wish we have it for every patient.
Well, those are great examples. Thank you, Mary. I know Florence might have to go in a minute or two. Thank you so much for participating, Florence. It was terrific, and I loved hearing your perspective. If you have to go, we understand.
Thank you so much.
We do have some questions from the audience, which I'd like to go through, and we'll probably go a little bit over time. So for those of you who want to stay, however, we'll be happy to take a few questions. I want to kind of touch on topics that we haven't touched on already, and there were 3 or 4 that caught my eye in the question and answer box. The first one is medical legal considerations. In other words, if we're going to use the physical exam, which I think we've all made a good case today, is much more cost effective and time effective than sending patients off to tests and other dalliances before they get their diagnosis, how do we deal with the issue of potential medical legal exposure there? And I'm interested in hearing Andre, Pete, any thoughts about that? Does it create problems? Is it a problem that really doesn't exist? We're just making something of it. How do we cope with that?
Yeah, it's a good question. It's a tough one for us to answer. I think, if anything, it's probably the other way around. That and I'll let Pete. I won't speak for Pete, but I think we've talked about it, and we've seen cases, and we've mentioned them today, where our eyebrows are raised when there's a lack of utilization of the physical exam that has resulted in delays in diagnosis and bad outcomes, rather than someone trying to utilize a physical exam and getting into a legal issue that way. So what I have observed has been the opposite to kind of how the question was phrased. But I think in general, as long as we're trying to do the best for our patients, that's all we can ask of any clinician, whether it's a doctor or a nurse or a respiratory therapist or anybody, as long as we're trying to do what we can for the patient. I think that we are setting ourselves up for success. And again, that starts with recognizing the utility of the physical exam. And so, when the physical exam is not utilized and results in a bad outcome, that's where my eyebrows are raised.
Yeah, I agree with that. I think that in the few cases that I reviewed as a consultant in medical legal situations, yeah, I always looked at what the physical exam was documented as having. And you could see right from the record when patients either didn't have an adequate exam and got into trouble, or things were discovered on the exam and then they were ignored by subsequent people, and they went down the wrong pathway. So I agree with you 100%. Pete, did you? I saw you unmuted.
Yes, I agree with Andre. Abraham Verghese has a piece a few years ago where his group at Stanford looked at exactly this, where diagnostic errors were made, and most often it was due to inadequate physical examination or physical examination not done properly or not interpreted. So as Andre said, I think the bedrock of diagnosis is a very careful history, a good physical exam that's going to be hypothesis directed, and then careful use of technology thereafter to further the diagnosis. And I think that using technology without any sort of hypothesis is just a scattershot approach, and more often than not, you're going to miss the mark and find things that are not true.
That's a great point. That actually leads me to my other question, and then I'll stop after that because we're already over time. But I wanted to get your thoughts about the different technologies that are coming out and what's really useful in sort of the routine situation. And that kind of bleeds over a little bit into telemedicine because some of these technologies can be used remotely. What do you consider to be fundamentally important things in the kit that people should be using? What do you think is, as you said, Pete, kind of shotgun or spurious or not really indicated? And I'm thinking about the different modalities that are becoming available as med tech goes toward the goal of all these different technologies. So, how are you seeing the landscape unfolding over the next few years in that regard?
There are some new technologies out there. So in addition to the electronic scopes that allow you to record sounds and amplify sounds, there are a lot of people that are becoming interested in using the point of care ultrasound. I think the point of care ultrasound is useful and effective in some situations, but to paraphrase Clint Eastwood, a person has to know their limitations. And I think that that's really true when it comes to point of care ultrasound. It's not the same as a formal echocardiogram. I don't think you can make the same conclusions about things like the valves. And Andre and I have seen a number of cases where people who do practice using the point of care ultrasounds have missed some pretty easy diagnoses that a stethoscope would have made. Wide open aortic regurgitation. The example I gave with the mitral stenosis, the point of care ultrasound was used in the emergency room before they ordered other technologies and the diagnosis wasn't found. And some of it is where did they point it? But I think that with any practice, whether you're talking about point of care ultrasound or the stethoscope, you want people to work on improving their technique and really putting in their hours, the 10,000 hours or whatever it takes to become really proficient. And my hope is that people who are using these technologies will put in the hard work that it takes to become proficient at it.
Yeah, I agree. And it's not that Pete and I are against technology. Obviously, we embrace it and we use technology as tools, when they're appropriate. I think it's just the misuse that is becoming a problem, or the replacement of the fundamentals of medicine with, devices and things that's where the problem comes into play. And, actually, one thing that Pete and I do, we tell this to learners all the time. If you do have the benefit of having an echocardiogram, a formal echocardiogram on a patient, and it shows a finding, use that to kind of help practice your skills. So if you see wide open aortic regurgitation, go to the bedside and feel the pulses, feel for the water hammer pulse, listen for that, decrescendo diastolic murmur, look for Corrigan's pulse in the neck, look for Quincke's pulse in the nail beds. That's how you're going to get better. And so we actually embrace technology on a number of levels. And recognize that everything is a tool in medicine. They're all tools. Even the stethoscope's a tool. And it's really though it's the replacement of the fundamentals, not taking a proper history or not performing a proper physical exam, and just ordering, as Pete mentioned, the shotgun approach, to all kinds of different tests and things. That again comes at a high cost, both literally and figuratively, for patients. So that's really where our passion lies, and trying to bring people back to the fundamentals and making sure we're utilizing the fundamentals. And then the fundamentals will help direct what tests you need. So, maybe you do need a cardiac MRI, but it really starts with a history and the physical exam. Maybe you do need a formal echo, but it starts with a history and the physical. You're not just getting an echo based on symptoms. And so, that's, I think, the position that we take on that.
Terrific points. Before we wrap up, Mary, any last thoughts?
Encourage people to take the time to help patients and families in home care get comfortable with the technology, because once they do, they have ready access to the care that they need, and it improves outcomes, it improves patient satisfaction and care in general.
Terrific, thank you. I see there are a lot of questions still unanswered, and we will try after the webinar is over to answer them offline. We'll circulate them to the panel and gather the answers and send them to you. So thanks so much. And I want to thank everyone who stuck around for the last few minutes after the hour to be with us. We appreciate that. Feel free, by the way, I'll volunteer everybody here. Feel free to reach out to the contact information you see here on the slide if you do have specific questions you want to direct to anyone in particular. I'd like to thank everyone for attending. I hope you found our discussion to be intriguing and thought-provoking as you go back for the rest of your day. And I would like to give my heartfelt personal thanks to the ECHO team that put this webinar together. They worked incredibly hard, and I think they did a fantastic job, and we're all indebted to them for making this webinar a success. And with that, I'd like to close it out and say to everybody, have a great day, and goodbye for now.
Thank you.